Okay, so we're going to review chapters 17 through 22, focusing more on the rheumatic and skin disorders than immunity. So just to review some of the things we talked about, allergic reactions. So allergies are an inappropriate immune response, so kind of that overwhelming response by the immune system where the limiting factors or controls within the body don't respond appropriately. And signs and symptoms of an allergic reaction are pruritus, where they get the itching, urticaria, where they get the hives, angioedema, where the lips, the tongues, and then you can have periorbital swelling as well. And it can manifest as anaphylaxis, which is where we have that overwhelming response, systemic response, and it's an IgE problem. So there's two or more body systems that are involved, and it's systemic, it's not a localized reaction. The treatment for anaphylaxis is intramuscular epinephrine. It's the 1 to 1,000 strength, and the dose for an adult, just so you know, in the EpiPen auto-injector is 0.3 milligrams. A pediatric auto-injector is 0.15 milligrams. And then remember we talked about you use the auto-injector in the lateral thigh, so kind of halfway between the knee and the hip, the anterior outer thigh. And remember that that needle that you can see there on the screen is ejected. The medicine then is injected through the needle for roughly 10 seconds with like a spring mechanism on the inside. So the needle has to stay in place for 10 seconds. Hold the leg nice and still so the person doesn't jerk their leg away or rip their leg away. Okay. One of the things that we know is true about allergic reactions is that the faster the onset of the reactions from the time of exposure, the worse the reaction will likely be. So if I get stung by a bee and I immediately have hives and swelling and wheezing or stridor and difficulty breathing, that is probably going to be a very serious reaction. If I get stung by a bee and a couple hours later I have some itching, that's most likely not going to be a very serious reaction. So because the bad reactions typically occur immediately or very soon after the exposure, it's really important that people with EpiPens have them on them at all times. They degrade very rapidly with exposure to heat, cold, and light. So they're supposed to be kept, like in your purse or on your person or in your backpack. They're not supposed to be left like in your car or in your glove box or anything like that. They're definitely not supposed to be stored in your car. So they should be on your person and with you at all times. All right, I drew this out for you on the board in class, but I'm just typing up for you here so you have it. So just the difference between natural and artificial. So natural is something that comes from a person versus artificial, something that can be made in a lab. And active, something that the person themselves creates antibodies from, and antigens and antibodies, versus passive, where the antibodies or antigens are antibodies are given to the person. So natural, active, the person has the disease, right? They develop memory cells, they develop antibodies, and the next time they are exposed, they more than likely will not develop the disease. Natural passive is what occurs during breastfeeding, where antibodies are passed from the mother to the infant through the breast milk. Artificial active then is injection of an artificially created or attenuated vaccine, and the person develops antibodies, but it's not a strong response as natural active, and therefore they might need boosters throughout their life. Passive artificial is probably the least effective, and it's just injection of actual antibodies at the time of exposure to something like, I think your book lists like rabies. So it's basically just giving the body what it needs at that very moment in time to fight off an infection, but there's no memory cells generated by artificial passive immunity. So we talked about the difference between HIV and AIDS. HIV is the virus itself, and AIDS is the syndrome of problems or illnesses that occur when the viral load gets so high that the system becomes overwhelmed. And remember that the virus can be transmitted through any contact where blood or body fluids can be transmitted from one person to the other through unintact skin or mucous membranes. And that includes sexual contact, parenteral, which would be like needles or IVs, and then perinatal, so during pregnancy and delivery. So blood, body fluids, the placenta, the delivery, and breastfeeding. So one of the problems with AIDS and what people usually die from are these opportunistic infections. And your book lists a bunch of them. Candidiasis, the oral thrush, remember we talked about that, is probably the most common one that you're going to see, just because the body, there's this overgrowth of yeast, the body can't fight it off, and yeast is very common in the body. An opportunistic infection means that, you have the microorganism or that flora on your skin or in your mouth or whatever, but normally your healthy immune system keeps it in check. But remember, when your immune system is compromised, those microorganisms then can flourish or can grow. So our goals for people with AIDS are to monitor for signs and symptoms of infection, sepsis, that things are getting worse. Signs of infection are not going to be any different. They're going to, have fevers. They're going to have exudate or pus. They're going to have, redness, warmth, edema, if there's a spot of infection. But if they get septic, they're going to have that same, tachycardic, tachypnic, hypotensive. They're going to be febrile, and because they're oftentimes, very ill, they often will also not have a lot of reserve. So look for signs and symptoms of dehydration as well, dry cracked mucous membranes, tenting skin turgor, things like that. And then Kaposi sarcoma is where you get those small purplish-brown raised lesions on the face, the lower legs, and then and then across the trunk. If any of you watched that Tom Hanks movie, they did a nice job of mocking it up in there. So on page 334 in your book, chart 19-3 lists those key features of AIDS, if you need to review those. We talked about 3 types of arthritis. So we talked about osteoarthritis, which is the progressive deterioration and loss of cartilage within the joints, right? And that can be from age, it can be from obesity, it can be from trauma. People usually have pain and swelling in the joints, and we treat it with NSAIDs and Tylenol. And we talked about if the joint is hot and red, you ice it, and if it is, cool and painful, then you can use heat or warmth. We talked about gout. So gout is technically gouty arthritis because those uric acid crystals form acutely in the joints and then chronically in the tissues. Remember, chronically in the tissues, they're called tophi. And then we talked about rheumatoid arthritis, and rheumatoid arthritis is truly not an arthritis in terms of like the OA, but it's inflammation and immune response that causes painful joint deformity. But remember that rheumatoid arthritis, because it's kind of an autoimmune disorder, attacks the entire body and causes fibrosis throughout the entire body. So we treat RA still with pain medications, but also with the biological modifiers. And when you start adding in the biological modifiers, the things that start to concern us then are the risk force, right? So I'm adding in steroids, immunosuppressants, methotrexate, chemo drugs. I'm adding in anti-immune function drugs. and I really increase the risk for infection, right? So you want to keep a careful eye on anybody who's on any of those drugs. You know, that's just kind of a common theme that's been running through this entire last 2 weeks. On page 309 in your textbook, chart 18-9 talks about nursing interventions for the patient with rheumatoid arthritis, and it does a nice job covering the key points if you need to review those. We have lupus. We talked about discoid lupus, which is just the skin, which is very, very rare, and then SLE, which is full body, which is the most common type of lupus. The kind of hallmark sign would be that butterfly rash on the face where there's dilation of the blood vessels to the face, but not everybody has that. Some people also have discoid skin rashes, and as you can imagine, if you have either the butterfly rash or the discoid skin rashes, then you will likely have a disturbed body image because they're often very dramatic when they're present. Key features of SLE versus scleroderma are listed on page 314 in chart 18-11. Just to kind of compare and contrast the two of those. But remember that lupus, even though it affects kind of the entire body, a lot of our interventions are external. So skin, hair, we're talking about using non-perfumed, very, very gentle soaps. I think your book even lists Ivory soap by name. Patting the skin dry rather than rubbing it dry, avoiding the sun, using gentle lubricating lotions but nothing with perfumes or dyes, monitoring very closely for signs and symptoms of infection. You know, I talked to you about my teacher always having to wear long sleeves and huge brim hats to avoid any sun exposure whatsoever, because even if we just walked across campus, her face would turn beet red just from being out in the sun. You know, other things that help during acute flare-ups, the body's working very hard, so they tend to need to conserve energy, so we would cluster our care, you know, things that we could do to help them avoid fatigue so they don't get too run down. Steroids as well, remember, treat those flare-ups, but they need to taper off so they don't kind of crash and burn like an Addison's crisis at the end. With steroids, just like any of these other ones, they're going to be at risk for infection, right? So monitoring for signs and symptoms of infection, so the fever, the chills, the you know, vital signs that change, the redness, the warmth, the exudate, things like that. And then with the alopecia, so the hair loss, things like the protein shampoos, or even for some, working your way towards a wig. So scleroderma then would be the SSC. So scleroderma has this very, we call it crest syndrome, so a set of symptoms that are kind of tied to scleroderma. So calcinosis are the calcium deposits underneath the skin. Raynaud's is where you get the decreased perfusion, usually in the ears, the nose, the fingers, and the toes, so the small vessels in the periphery. Esophageal motility, dysmotility. So remember that if the person is not moving things through their stomach well, that they are going to have a lot of reflux. They're going to be high risk for aspiration. And just like anybody else who's an aspiration risk, the head of the bed really should be elevated 90 degrees for meals and for at least, you know, an hour afterwards. Same for meds, you know, just get the head of the bed up. Because things don't tend to move correctly, and also as there are changes within the GI tract itself, the person usually starts to develop malnutrition and weight loss with the scleroderma. So there's a lot of GI issues besides the esophagus just not working correctly, but we needed a vowel, I guess, to put in there. Sclerodactyly, so the thickening and tightening of the skin on the fingers and the hands, and I showed you a good picture of that in class. And then the telangiectasia, which is hard to say, is where we have the dilation of the capillaries on the surface of the skin, not like a spider hemangioma, but just little red dots. And scleroderma was the one where we talked about where if the person has like severe Raynaud's, or if they have a prolonged period of time without perfusion, they can have the auto amputation of the distal digits, which I don't know about you, but doesn't sound like a lot of fun to me. So that's just a brief kind of review of a lot of the information that we covered, and I hope that helps you